بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على نبينا محمد. أول شيء أبارك لكم بالعشر الوسطى، العشر الأولى راحت، الله يجعل إن شاء الله ميزان حسنات الجميع. Well, today our lecture will be about facial palsy and facial spasm. Facial nerve per se, it's really a huge topic. So what I'm gonna try to do is just to give you some of the tips that I learned, and I think it's really good for you to be aware of, and to tell you just to read about the topic, because the topic is so huge. I mean, if you go to the ordinary library, you'll find a huge textbook about facial nerve. And the interesting part about facial nerve, it's not only in ophthalmology. You can find it in neurology, ENT, so it's also in the plastic surgery textbook. So it's a nerve that combined many different specialties and taking care of one patient. Before we start, all of you know that facial nerve is really vital for person well-being, functionality, and psychology, and also emotion. So it's not just function. When a patient with facial palsy gets the facial palsy, they become more isolated. So they need emotional support, psychological support, plus the functional support that all of you are aware of. So we need to take care of that in account. Just a few points about facial nerves. Facial nerve is one of the big cranial nerves. It contains around 10,000 nerve fibers originating from the brainstem nuclei. The facial motor nucleus controlling muscle of facial expression. Superior salivary nucleus innervate the lacrimal and salivary glands. So facial nerve also serve in tearing and lacrimation and salivation. Nucleus solitarius received fibers of taste from the anterior two-thirds of the tongue, and the trigeminal sensory nucleus getting sensory fibers for the small portion of the external ear. So it's mainly a motor function nerve, but it has some sensation and secretory functions. And all of you are aware of this anatomical sketch for facial nerve, and this is the brainstem. And you can see the different nuclei that helps in forming the main bulk of the facial nerve. Then after that, it exits the brainstem through the auditory canal. Then it goes through the facial canal. Then after that, it will exit through stereomastoid foramen. Then after that, in the parotid gland get divided in different branches that we're going to touch in a minute. One of the things that really help localizing the facial nerve injury is to see if the nerve to stapedius muscle get injured. If the patient come with the ear complaint, that means the injury is here and above. If the patient came with without ear complaint, that means the injury from here and below. And other thing that's really related to ophthalmology, if the ear is affected, there is a high chance for the lacrimal gland to be affected, because the nerve that helps secreting the tears, it leaves almost in a similar location or a similar level to the nerve that go to stapedius muscle. So this is one of the symptoms you ask a patient when with facial palsy to see if there is any ear complaint. Because if they have ear complaint, there is a good chance for the hyposecretion of the lacrimal gland. So that will complicate the issue of managing dry eye secondary to facial palsy. But if there is no ear complaint, that means it's below, and most likely the lacrimation will not be affected. This is a nice drawing you see in textbook, while in reality, especially in the recent description, it's not like this. You don't see the nerves like the temporal branch, zygomatic branch, and buccal and mandibular. Usually it's more of fine branches that supply one area. It's not only one bulk like this, more of divided. And this drawing mainly to make it simple for people to understand. You know, we see in the clinic, in ophthalmology clinic, upper or motor neuron lesions. Lower, yeah. The upper doesn't come to us because the upper part is preserved in the upper motor neuron lesion. And there are multiple causes for lower motor neuron lesion. And one of them is infectious process, inflammatory process, traumatic, iatrogenic, congenital, idiopathic, and neoplastic. What do you mean by iatrogenic? Which the most common surgery? Parotid gland, that's very good. What other? We see mainly in our clinic or in our hospital. Yeah, middle ear infection, middle ear surgery. Here, one of the things that I want to touch and spend some time is the facial nerve presentation in adult and childhood. In patient in adult, usually they present, especially elderly, they typically present with eyebrow ptosis, lag of thalamus, ectropion, upper eyelid retraction. It's very common if you pay attention for it. Exposure keratopathy and epiphora. These are the ophthalmic manifestation of facial nerve palsy in adults. And this is a typical example. You can see this patient. When you don't see the brow ptosis much because already he has a senile brow ptosis on both sides. But you can see the lid retraction clear. Do you see that? And you can see the ectropion. You can see the laxity of the lid. And you can see the rest of the facial involvement by facial nerve. One of the important thing is that you face in the clinic or they are when a patient comes with facial palsy, do you need to image or not? And this is what we're going to touch in a minute. Plus, what lab investigation you want to order, because we just mentioned, the etiology is variable. So it can be infectious, inflammatory, traumatic, iatrogenic, congenital. So it depends on the patient presentation. For example, if a patient is presented secondary to a middle ear infection, and you can just refer to ENT, then from there they will investigate what could be the reason. They just, maybe clinical exam is enough. Maybe they want to order CT scan for temporal bone to rule out cholesteatoma or other inflammatory related condition invading the facial nerve. Inflammatory condition also can be related to like sarcoidosis and other inflammatory conditions. So we need to ask in details about the inflammatory condition. Trauma, that's definite. If a patient comes with recent trauma, it's good to do the CT scan to localize the place of the trauma, and especially nearby the temporal bone. Congenital, usually diagnosis by exclusion, also by history. Idiopathic and neoplastic, also you need to rule out by proper imaging to the area or localized area that you think this patient is most likely having the facial nerve injury at. Imaging, typically we ask for imaging if it's a slow onset of symptoms, if patient is gradually losing the facial nerve function, because if acute onset like Bell's palsy, it happens immediately. It doesn't come gradually. But if there is a gradual onset, that means there is slowly process, either tumor or inflammatory condition that eating in the nerve or oppressing in the nerve. So a slow onset of symptoms, this is one of the indication. Other indication, no return of function after 6 months, because typical Bell's palsy, it improves. So if it doesn't improve, you need to rule out other possibility. Other thing is recurrent ipsilateral. Also, you need to investigate that. And also people also highlighted if it's multiple cranial nerves. If it's, for example, 7 and 8 or 7 or 6, maybe something in the brainstem, so you need to imaging. But bilaterality, some people they image, some people they don't image. But it's good to be safe and image in this. One of the things, we don't see it here, but it's good to be aware of. Facial palsy can be a presentation of giant cell arteritis. It's been reported in the Western literature, but it's not in our patients. So you need to keep that open. So if a patient, especially elderly, came with what looked like ischemic facial palsy, you need to ask about symptoms and signs of giant cell arteritis, because it could be the initial presentation, facial nerve palsy, not optic nerve injury secondary to giant cell arteritis. So this is something really good to be aware of. When you, after making your diagnosis, you go for a treatment, and always our job is to make diagnosis, because if you make the diagnosis, you can reach to the proper treatment. But if the diagnosis is not made properly, the treatment will not be accurate. So how you manage ophthalmic manifestation in patient with facial palsy? As we just illustrated earlier, that facial palsy is a condition or a problem that needs to be tackled by multiple teams, not only ophthalmology alone, but you need to involve ENT, neurology. It depends on the patient presentation, also the diagnosis. So it's always good to treat it as a group, not an isolated specialty. Other parameter that we depend on the treatment is, do you expect recovery or not? Recovery not expected, because it's also this one will change the management plan. However, if you have the recovery is expected, we use most of the time is a temporary measure. What's the temporary measure? You use a topical ocular lubrication with artificial tears during day and lubricating ophthalmic ointment during sleep or even during the daytime. You can use occluding the eyelid by using tape or by applying patches. Temporary tarsorrhaphy with suture or cyanoacrylate glue. Also, you can use Botox injection to paralyze the levator muscle. So these are options to temporary helping the eye to be lubricated till the recovery or the restoring of function happens. And this is just illustration for temporary tarsorrhaphy that most of you are really good at, because اللي كان معنا في التيم الأسبوع الماضي الشهر الماضي سوى 2 أو 3 ف it's something we do frequent, so it's good to be aware of, and it's very simple to do. ما جاء محمد الأسمري. And this is a typical patient for that you expect recovery. This patient diabetic for a long time, and you expect the patient has ischemic facial nerve, and this is his. You can see the eyelid manifestation, also the facial manifestation. This is his picture 3 months after. So you can see the full recovery which was expected in his condition. However, the recovery is not expected, or the patient end up with a permanent damage. For example, the patient underwent parotid gland tumor removal, and the facial nerve was removed during surgery. So you don't expect that to recover. So you go for permanent measure immediately, or the recovery didn't happen. So what options or what things you need to tackle is correction of lag ophthalmos. We can use gold weight, or recently I'm using more of platinum chain. That will give better action and also less bulky on the eyelid. Also, you can do eyelid recession, because we agreed one of the manifestation of facial palsy is, yes, upper lid retraction, either upper or lower. Lower eyelid drops and ectropion, this need to be tackled and managed. And also the brow ptosis and blepharoplasty whenever it's needed and concern for the patient. One of the things that I want to highlight here is the function of eyelid weight placement, either gold weight or lag ophthalmos. The main function here is to improve the blinking. It's not to improve the lag ophthalmos per se. And this is just to show you, this patient is facial palsy in the left side, and you see him is blinking. So when he has some aberrant regeneration, because this is an old facial palsy. So look at here after we put a trial of weight. So we put a weight to stick it outside. So this is the common thing we use in the clinic before placing the permanent weight. And you see the improvement in the blinking. You see the improvement in the blinking. And this is the way you place it. You place it in the top of the tarsus. I like to placing it a little bit to the upper third of the tarsus, along with recessing of the levator aponeurosis, so it will help dropping the eyelid. Initially, when I put the gold weight or the platinum, I like to have it a little bit ptotic, like 1 millimeter, 1.5, because gold weight is work as a muscle exercise for the levator muscle. So whenever they blink, the muscle will be stronger, like lifting weight. So it will correct itself after a while. So it's just something I anticipate that it's gonna instead of having patient after a while to have lid retraction, it's good to have him ptosis and lid retraction after a while. Lower eyelid laxity is very common presentation, especially in elderly, along with the mid-face descent in patient with facial palsy. This can be corrected by tightening the lateral and medial canthal tendon, like in this patient. Other way of managing the lid laxity and ectropion is to do permanent tarsorrhaphy. And this is the lateral tarsorrhaphy. And the procedure, there are different ways of doing it and different description, but this is one of the easiest one that you find in Dr. Nira's book. So you separate through the gray line the anterior lamella from the posterior lamella. Then after that, you depithelize the posterior lamella all the way. Typically, if we are doing the lateral tarsorrhaphy, you go up to the lateral limbus to have really effective lateral tarsorrhaphy. Then after that, you suture the posterior lamella together, then the anterior lamella together, and paying attention to have the lashes pointing away from the eyeball. And this is the end result you have. Myself, I hate this procedure, and I don't like it because of this appearance. I get so many patients, they coming, they said, "Doctor, can you open the eye?" I said, "Oh, you're gonna have dryness." They said, "I don't care. The way I look, it doesn't look good." I've been moving more toward the paracentral. I found it really as effective as lateral tarsorrhaphy, and also the way it looks is better. Like this, if you see this patient, this is what I call the paracentral. So you go lateral to the punctum, and just at the level nearby the middle limbus, and you suture. You do the same procedure, but in this area. This will help two function. One of the appearance is better if you compare this appearance with the previous one. Other thing, in this eye, when you do the lateral tarsorrhaphy, you will block the peripheral, the lateral field of vision. While if you are doing this one, the field of vision will be open for the patient. So you are saving both better cosmesis and better functional visual field. And many patients, they like it when they switch to this procedure. What about epiphora? This can be secondary to reflex tearing from the dry eye or exposure keratopathy, can be resulting from the paralytic ectropion that these patients typically present with, and also can be secondary to hypersecretion or aberrant infiltration of the lacrimal gland, which sometimes we see and we call it crocodile tears. Yeah, this is one of the things that we see. How we manage reflex tearing, dry eye, with lubrication and improving the blinking, and also with the lateral tarsorrhaphy or paracentral tarsorrhaphy, all measured to help the eye to be comfortable. The paralytic ectropion, we manage it with lateral tarsostrip or mid-face lift. And sometimes if it doesn't work and the patient still have a problem, you may go for DCR or Jones tube. And how you manage the hypersecretion with aberrant innervation of the lacrimal gland? Botox injection. Here, we find that the presentation of facial palsy in children a little bit different than adults, because the facial tendon and the connective tissue in children is a little bit different than adults. So in children, the tendons are tight, and also subcutaneous tissue more tight. And even the upper medial and lateral canthal tendon are tight in children compared to adults. And this is one of the best patients. Like immediately after I joined from the fellowship, I faced this patient. This patient, she developed facial nerve palsy secondary to middle ear infection. And she presented with entropion, not ectropion, which doesn't go with the textbook. So from there, I start collecting patients. Then we wrote a small series, Borfiasser and me, about facial or ophthalmic manifestation of facial palsy. So entropion is one of them that we found it in some of them. And this patient just pre-op and post-op. And this patient also presented after I became interested in this. And you can see this is not a frank entropion, it's more of marginal entropion. You can see this is the facial palsy in the right side, and you see the eyelid in the right side, and you see the eyelid in the left side. You can see the lashes pointing the way, and the lid margin, you can see it clear. Here you don't see the lid margin clear. So when you don't see the lid margin clear, we call it marginal entropion. One of the other thing is, I observe in these patients, they come with other complaints like dryness, and you discover that they have lower eyelid retraction. If you look at his eye, you didn't see anything wrong apart from the lower eyelid retraction. And most of these patients, especially if they got it for a few years or so, they forget about facial palsy. And the only way is to ask him about it. And you see this patient, when you ask him to raise his brows, and this is what you see. So lower lid ectropion, especially in young patients, you need to raise suspicion of facial palsy, okay? Why is this? As we just mentioned, that the laxity in the tendon and also the strong connective tissue in adult is in children is more strong than adult. And this is another patient. She had facial palsy in the right side, and you can see the lid retraction, and this is after surgery. And this is a child with facial palsy after a cochlear implant, and you can see the cheek is droppy. So still you can have the droppiness of the cheek even in children. So it's not like doesn't happen in children, but it's less frequent than in adult. And what happened in children, because they get it early in life, they tend to have atrophy of the cheek muscles. And maybe you see it clear in this patient. Because of the muscle innervation is interrupted in the muscle for a long time, they developed atrophy secondary to that. One of the things that we see after facial palsy is aberrant regeneration. It happens in different flavors. And this is happened because following peripheral facial nerve injury with axonal damage, axonal regeneration begins at approximately 3 months. After the lesion, after the insult. So the insult happens, and after 3 months, the regeneration happens. And with this regeneration may lead to infinitely to clinical evident or subclinically hyperactivity of the previous paralyzed muscle, meaning the nerve injured, then after that the repair happens. Sometimes the repair happens more than expected or more than normal, so that will lead to overaction of the muscles. And this is what I'm trying to illustrate in this. You see this patient had old facial palsy in the right side. You can see the right eye opening is smaller. Why? Because of hyperactivity of orbicularis muscles. So this is again one of the things that you may see in the clinic. The patient comes complaining of one eye smaller than the other. And if you dig in history and ask them about old facial palsy, they tell you about. So this is one of the frequent things I see presenting a facial nerve palsy as an old facial nerve palsy. So something to be aware of. Other thing we just mentioned about before is aberrant regeneration. So when when the patient moves the mouth, for example, the eyelid close, and the other feature we just mentioned, the crocodile tears. So when they eat, the eye tears. And this is one of the really common things I see is this one. This patient had facial palsy in the left side, like I think a year ago before a presentation. What do you call this one, Ahmed Dail? Huh? Post-paralytic spasm. Because you remember we talked about regeneration happen, and sometimes the regeneration is more than we expect or more than we like. So the patient either end up with hyperactivity and causing the eye to be smaller, or they can go for spasm. So we call it post-paralytic spasm. And there is no clear margin between post-paralytic spasm and hemifacial spasm. عشان كده الدكتور أحمد قبل شوي, and this is his interest. Literature not differentiating clearly what's hemifacial spasm, what post-paralytic spasm, because people are mixing it up. Blepharospasm, it's involuntary tonic spasmic contraction of orbicularis muscle. So blepharospasm is both eyes. Hemifacial spasm or paralytic spasm, it's one eye, okay? And before diagnosis of blepharospasm, we need to rule out ocular local cause for eye irritation, like dermatochalasis with rubbing eyelashes, brow ptosis, and ectropion or entropion or dryness of the eye. A hemifacial spasm is a form of spasm that happens as an intermittent contraction of the entire side of the face, and the way to differentiate it is it hemifacial spasm or blepharospasm that is present during sleep. So hemifacial spasm typically present during sleep. And one of the things that you need to do is ruling out facial nerve injury or facial nerve compression. So we need to do MRI to rule out that, and that's why people think still there is no clear margin about post-paralytic spasm and hemifacial spasm, because both of them, they may result from facial nerve injury. How we treat the blepharospasm or hemifacial spasm or post-paralytic spasm? We use Botox injection, and this will block the neuromuscular junction. Typically we use type A botulinum toxin, so it will release block the release of acetylcholine. And as you know, it works within 3 days, and it peaks within 1 to 2 weeks, and the duration about 6 to 12 weeks. And this is typically the appearance and the site you inject. For peripheral spasm, we typically inject 4 units in each side. For hemifacial spasm or post-paralytic spasm, I tend to decrease the dose because the sensitivity is higher. So I will start with 3 instead of 4 or 5. So peripheral spasm, we start with 4 or 5. But with hemifacial spasm or post-paralytic spasm, the muscle are more sensitive to Botox injection. So I give lower dose. And for eyes, for patient with eye being smaller on one side than others, I give 2 units only. So I inject here, 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 and here, 2 units. That will help the eye opening to be equal with the others. So peripheral spasm, I give 4 or 5. Hemifacial spasm, post-paralytic spasm, I give 3. And to make the eye opening bigger, I give 2, sometimes 1.5. And that's it. Any question? Since there is no question, I will ask them. Abdullah, what surgical option you have for lower eyelid laxity? How you manage? Because some patients, they present with our lower lid laxity and lid retraction. How you manage these surgically? How you tighten? Okay. Lower retracted what? Why? Yeah, we're talking about paralytics, huh? Okay, that's good. Is anybody interested to add more procedure? Fasciolata, what you call that one? What you call the procedure? Sling, lower eyelid slings, huh? Yeah, this is one of the options. What else? Mid-face left, that's very good. So use it with suture, or you can use it with fasciolata too, the slinking procedure for the mid-face. What else? Yeah, that's good. It's a form of tightening of the lateral canthal tendon. That's very good. What else? Remember we talked about lower eyelid retraction. So you can do release of lower lid retractors, and you can put a spacer. You can put, for example, dermis fat graft. You can put permanent spacers. So this is one of the other options you can do. Other thing you can do is you send the patient for facial plastic surgeon to do what you call it nerve transplant. That will help regaining the cheek function. That will help improving the lower eyelid position too. And this is not common in Saudi Arabia, but in some parts like in Boston and UK, they do it frequently. I'm not sure if Brazil did they do it a lot or not. Yeah, but here not many people are interested on it. So.
I have a question.
Go ahead.
Because in the beginning, when we have the Thank you for the lecture. Very interesting. At the beginning, when we have the palsy, if we apply laser in the channel,
And the canal.
yes, we can have less lesions. We usually do this, and physiotherapy also. Sometimes I am not doing the tarsorrhaphy because to do the physiotherapy, this can be something that's not good.
Okay.
And I have very nice results with physiotherapy. I usually say, because I work in the university and we have a lot of departments, and we have a physiotherapy department. I usually say that they are destroying my surgeries because the patient improve. But we need to do this with 72 hours period when they start the palsy till the treatment, to start the treatment.
So you use physiotherapy or electrical therapy?
Yes, they combine many kinds of physiotherapy, but I think the most effective is the laser in the channel.
Where do you apply the laser in the stereo?
I am not doing it. I send the patients for physiotherapy.
I see. And what one of the common questions I expect the resident to ask me, so I will ask it to you before. When you get a patient with Bell's palsy, do you give steroid? Do you give antiviral, or what's your approach for this?
No, I'm not. I'm not giving. But sometimes when the neurologists work with us, they usually give.
They give both?
Yes. And another thing, you put the. Okay, you can. You talk about this, and then I will have another question.
No, but I mean, after presentation, by 1 day, 2 days, you give the steroid, or you can give it even later, a week after.
I think to have the effectiveness, it's better to give in the beginning.
Yeah.
In the beginning, because it's to prevent the edema. If you have the edema, you will have the lesion. Yeah. It's to prevent the edema.
Yeah, because I see some people, they're doing it after 2 weeks or so. I think that's
it's very late.
Helpful. And also in the literature, there's still no clear agreement about giving antiviral, because some people, they think it's a herpetic infection, some people think it's more of postulated. So I'm not sure of really a good guideline for it. So unless somebody is aware of a good guideline, share with us. But steroid, most of the people are giving. But antiviral, I'm not sure. Is anybody having any answer different? Go ahead.
About the tarsorrhaphy.
Yeah.
Because many patients are older and they have diabetes and they don't have good production of the tears. And also because the palsy will affect the production of the tears, will be less. Because this, I prefer to do if I see the patient doesn't have tears, I prefer to do the tarsorrhaphy in the lacrimal part of the lid. Closing the canaliculus. Open the canaliculus, closing the canaliculus.
You mean medial tarsorrhaphy?
Yes, medial. I think it's good because it will not distort any tissue.
True. That's very true. Any question? Okay, maybe break for 5 minutes or so before the second lecture.
تنسى. في بوينتر.
في بوينتر. هذا هو البوينتر.
طيب
بس ترى الدكتور ما يقول بس تقلب الحين ما
طيب مو مشكلة.
يعني اشبك دكتور اشبك
اي خلاص.
بسم الله الرحمن الرحيم. كل عام وانتم بخير. Today our grand round will be in uveitic glaucoma. As you know that glaucoma is one of common complication of uveitis. And glaucoma occur in about 20% of cases of uveitis. Majority of uveitic cases in Saudi Arabia, as we know, like VKH, the treatment of uveitic glaucoma, either medical or surgical, about 70% of patients respond to medical treatment, and 30% will respond to need surgical intervention. Our speaker today, Dr. Faisal Mubarak, Chief Glaucoma Unit, King Saud University, Assistant Professor, will discuss in detail the surgical management of uveitic glaucoma. Welcome, Dr. Faisal.
Thank you very much, Professor Isam. So our talk today will be about surgical management of uveitic glaucoma. As we know, uveitic glaucoma was first reported by Joseph Beer in 1813. The prevalence ranges between 5 and 42% among uveitis patients, and it's influenced mainly by the underlying disease, duration, and age. So in children, it's a lower prevalence, ranging between 5 and 13.5%, but the visual prognosis is poor compared with a higher prevalence in adults, but with a better visual prognosis. The incidence increase with chronicity of the disease, so it increased from 7, 11 up to 23% in chronic uveitis after 10 years, and it's associated with more visual loss. There are some certain uveitis conditions which are associated mostly with uveitic glaucoma or with secondary glaucoma, including anterior, intermediate, posterior, and panuveitis. Mainly in anterior uveitis, we have idiopathic uveitis, herpetic uveitis, arthritic, and Fox uveitis, and post-Schwarzman disease. Intermediate uveitis, mostly sarcoidosis and TB. Posterior uveitis, toxoplasmosis, and panuveitis, TB, sarcoidosis, Behçet, VKH. Risk factors for developing glaucoma are mainly in adults, chronicity, age, activity, and steroids, while in children, it's JIA, ANA positive with no arthritis. So what's the risk factor for, or why do we develop actually secondary glaucoma in patients with uveitis? To understand the pathophysiology, we need to know that there are two broad classifications of uveitic glaucoma. We have uveitic open-angle glaucoma and uveitic angle closure glaucoma. So there are some certain morphological changes in patients with open-angle uveitic glaucoma, which include mechanical blockage and cellular depletion, trabeculitis, damage to the trabeculum and endothelium, secondary to chronic inflammation, steroid-induced glaucoma, and patients who are already having primary open-angle glaucoma with or exacerbated or worsened by the development of uveitis and secondary high IOP. We have uveitic angle closure glaucoma, mainly attributed to the development of posterior synechiae and pupillary block, peripheral synechiae, forward rotation of the ciliary body, and medications such as pilocarpine, and patients who are already having primary angle closure glaucoma. So to understand the pathophysiology in depth, we know that in open-angle uveitic glaucoma, we have disruption in the ciliary process and blood-aqueous barrier, and we have plasma protein and inflammatory cells such as neutrophils and T cells access the anterior chamber with secondary inflammatory mediators affecting the trabecular meshwork and resulting in scarring, plus the additive effect of steroid, which is commonly used in patients with uveitis, which will take 2 to 6 weeks, with extracellular glycosaminoglycan, fibronectin, laminin, and collagen, and it will inhibit as well phagocytosis. All of this will result in blockage of the trabecular meshwork and scarring with increased outflow resistance. So what will exactly happen in disruption in the ciliary process and the plasma protein and inflammatory cells egress to the anterior chamber? There will be an elevated protein content in the aqueous, resulting in high intraocular pressure, mechanical blockage of the trabecular meshwork by proteins, fibrin, inflammatory cells, and debris, and increased extracellular matrix and loss of inner wall of endothelial cells, which will result again in blockage of trabecular meshwork and scarring. Inflammatory mediators can cause constriction of trabecular meshwork endothelium and change its size. Prostaglandins such as E2 and E1 and E2 increase the IOP, but keep in mind that F2 alpha decrease the IOP. Cytokines can exacerbate inflammation and promote neovascularization. Interleukin-1 can increase the uveitic outflow and decrease the IOP, but decrease the conventional trabecular outflow as well. Lastly, steroids can increase the IOP in 1/3 of uveitic cases. It's depending mainly on the dose, composition, route, frequency, duration, and susceptibility to steroid response. We should keep in mind that actually 5% of population are steroid responders, and there will be an accumulation of glycosaminoglycan in the trabecular meshwork, and inhibition of phagocytosis by the trabecular endothelial cells, and inhibition of synthesis of certain prostaglandins, which will result again in blockage of trabecular meshwork and scarring. While in uveitic angle closure glaucoma, there will be organized inflammatory products in the angle and granulomas with new vascularization of the angle and preventile synechiae, which will widen with time and result in angle closure. Posterior synechiae resulting in pupillary block and ciliary body and choroidal edema, which will cause anterior rotation of the ciliary body and secondary angle closure. There are some specific uveitis entities associated mostly with secondary glaucoma, mainly Posner-Schlossman syndrome, Fuchs uveitis, herpetic uveitis, and JIA. So just we'll have an overview about certain uveitis entities such as Fuchs uveitis, for example, which is a chronic low-grade inflammation in which glaucoma development depends on the duration of the disease. You will notice that there is no preventile synechiae and no posterior synechiae, and there will be medical therapy usually the medical therapy usually fails, and filtering surgery is mostly required in those patients. In Posner-Schlossman syndrome, there will be recurrent episodes of mild inflammation and high IOP with an open angle, and the development of glaucoma will increase when the number of episodes or duration of the episode is long. So the risk will increase by 3-fold when the duration of the disease is more than 10 years, which will eventually require filtering surgery. In JIA, the most important thing is that persistent low-grade inflammation is the single most important high-risk factor or factor for developing glaucoma. There will be an open angle or sometimes closed angle. It's mostly with the oligarticular JIA and needs strict control of inflammation along with immunomodulatory therapy to help control the low-grade inflammation that patients are already having. In herpetic uveitis, uveitic glaucoma is the most common complication of herpetic uveitis. There will be inflammation of the trabecular meshwork with open angle, and synechiae and fibrin deposit might develop in severe cases. There will be a better response to medication. However, in severe cases, surgical intervention is often required. Again, VKH, it's a bilateral disease, can present with open or closed angle. The management of closed angle is challenging because there is edema and anterior rotation of the ciliary body. And the long-term prognosis of uveitic glaucoma associated with VKH is unknown because it depends mostly on controlling the inflammation. Sarcoidosis, again, there will be bilateral disease. Most cases, they might have open angle, but sometimes with the deposition of granulomas in the angle, you might have synechial angle closure. The long-term prognosis as well, it's not known. So mainly the management of uveitic glaucoma depends on the accurate diagnosis of the uveitis entity. Treating subsequently the inflammation, controlling the IOP, and surgery is required in up to 50% of cases. So treating the inflammation is the key towards successful IOP control. Managing patients with uveitic glaucoma have two arms, mainly medical and surgical treatment, and we'll be focusing on the surgical treatment. Surgical treatment is unfortunately required in up to 50% of cases in our community, according to a paper published by Rubaiyah in the Journal of Ocular Immunology and Inflammation 2016. It's a complex mechanism, and we need actually to make sure that the inflammation is under strict control to have a successful management. So the activation of the inflammation and the associated uveitis complications are also most important additive factors toward failed surgical or medical management. We should remember that uveitic glaucoma include a wide range of disorder, and the patients are relatively younger than patients with primary open-angle glaucoma, and that's an additive factor for the difficulty in managing such patients. And the IUP elevation is actually higher, and there are some variable responses to anti-glaucoma medications in patients with different uveitis entities. So, to have a small conclusion, up to 50% of eyes will definitely require surgical intervention. The success rate is ranging between 50 to 100% depending on restrictive inflammatory control, but the long-term outcome is still not known till now. The success rate is lower than patients with primary open-angle glaucoma, and again, this is attributed to the presence of the active inflammation. And we should remember that opposite to patients with primary open-angle glaucoma, hypotony is a real threat in patients with uveitic glaucoma. So when can we operate patients who are having actually uveitic glaucoma? We should keep in mind that we should control the inflammation. Why is that? Because we need to reduce the conjunctival inflammatory cell population to have a successful filtering procedure. However, the issue is that uveitic glaucoma surgery is rarely done on elective basis. So perioperative control is crucial. So we need to have a good communication and consultation with the uveitis specialist and the uveitis team. Now to talk first about trabeculectomy, which is the classical procedure of choice in glaucoma and in uveitic glaucoma as well. 50 to 90% is the reported success rate, but there is a high risk of cataract progression. There was one paper reported by Kaburaki et al. In 2009 in Eye, which showed that actually there is no difference in the efficacy and safety of trabeculectomy between primary open-angle glaucoma and uveitic glaucoma, given that you will have inactive uveitis. However, hypotony maculopathy was more detected in patients with uveitic glaucoma. Risk factors for failure of trabeculectomy with uveitic glaucoma include previous cataract surgery and patients who are having granulomatous uveitis because of the fibrotic tissue and granuloma containing Langerhans cells accumulating in the trabecular meshwork, and therefore filtering pathway is subsequently closed. The indications of trabeculectomy in uveitic glaucoma, it's uncontrolled IOP. You can do it in patients who are having either open or closed angle with no conjunctival scarring or thinning, which will be a risk factor for bleb leak later on and endophthalmitis. You can do it in phakic eye, pseudophakic with collagen, and no other hypotony risks such as young age, which is a relative contraindication. However, there are some certain risks in performing trabeculectomy in patients with uveitic glaucoma. The most important thing is cataract development and progression, which is increasing up to 30% after trabeculectomy in uveitic glaucoma, followed by activation of uveitis and inflammation. And the third most important risk, which is increased, is hypotony. So why do we have actually prolonged hypotony after trabeculectomy in uveitic glaucoma? Well, because of the uveitic damage to the ciliary body itself and the prolonged use of mitomycin, so we need to use it judiciously. There have been 2 publications in the Journal of Glaucoma about the outcome of trabeculectomy in uveitic glaucoma, which was done in Kekish. The first paper is about the intermediate and long-term outcome of mitomycin-enhanced trabeculectomy as a first glaucoma procedure in uveitic glaucoma, which includes 70 eyes of 50 patients. Most patients who were recruited were having pan-uveitis, followed by anterior uveitis, then intermediate uveitis, and the most common disease was VKH, followed by idiopathic Fuchs and Behçet disease. The baseline IUP was 39, which decreased significantly up to 6 years follow-up to 15.1, while the number of medication was 3.7, which decreased to 1.3 at the last follow-up after 6 years. Regarding the postoperative complications that develop after trabeculectomy in uveitic glaucoma, the most common early complications were hypotony, IOP spike, and hyphema, while the late complications were cataract development and progression reaching up to 45%, followed by hypotony and glaucomatous loss of vision because of uncontrolled intraocular pressure. The Kaplan-Meier survival curve showed that there is a progressive decline in the success rate of trabeculectomy in patients with uveitic glaucoma, and the most important risk factor for this is the development of on and off activation of the inflammation and the natural course of trabeculectomy. We did a sub-analysis on patients with VKH who underwent trabeculectomy with mitomycin C, and we found out that the results are almost the same. So the baseline IUP was 40.2, while the baseline medications was 3.9, which decreased after 4 years to 15.3 and 0.7. While the early complications were hypotony, choroidal effusion, and decompressive retinopathy, compared with late complications consisting of mainly cataract, uncontrolled IUP, and glaucomatous complete loss of vision. The Kaplan-Meier survival curve is almost identical when you go to the 48 months point here. compared with the point here in the intermediate and long-term outcome paper. And when we actually compare the results that we had, and we divide the patients to two groups, patients who are having granulomatous and patients who are having non-granulomatous uveitis, we can see that actually the outcome is almost the same. So there is no difference in patients who are having granulomatous and patients who are having non-granulomatous uveitis who underwent mitomycin-C-enhanced trabeculectomy. And the trabeculectomy success rate in different publications is almost the same, depending on the case series and the number of eyes involved and the follow-up period. Now, when we move to express shunt glaucoma surgery, we know that it's a metallic implant that drains the aqueous into the subconjunctival space. It's less invasive than traditional trabeculectomy because there is no sclerectomy and no peripheral iridectomy, so subsequently we'll have less inflammation. And theoretically, this might be really advantageous in patients with uveitic glaucoma. Lee published a paper about the safety and efficacy of express shunt in patients with uveitic glaucoma. He had a 6-month follow-up, and the reported complete success rate was 80%, while the qualified success was 100%. The postoperative hypotony due to ciliary body shutdown occurred in 20% of cases, one of which was complicated by choroidal detachment and long-term hypotony maculopathy. So larger trials are warranted to establish long-term efficacy and safety of express shunt. Now, when we talk about deep sclerectomy, it really needs an open angle, and superior open angle is enough. There is no entry to the anterior chamber, no iris manipulation. Subsequently, we avoid prolonged hypotony, and we avoid associated inflammatory response after surgery. The indications are, again, uncontrolled IOP, open angle at least superiorly with no conjunctival scarring or thinning, phakic, pseudophakic with caution, and it's suitable for patients with a high risk for developing hypotony, such as patients with young age group. So what will happen in deep sclerectomy is that we'll have controlled outflow of aqueous humor through the trabecular window. It will reduce the risk of profound and long-term hypotony and prevent egress of cytokines and inflammatory mediators from the anterior chamber to the subconjunctival space. And subsequently will reduce the risk of inflammation, scarring, and failure of filtering surgery. So it generates less inflammation during the early postoperative follow-up and requires close monitoring for appropriate adjustment of the IOP lowering interventions such as goni puncture. We should know that trabeculectomy leads to high transit postoperative inflammation but facilitate direct IOP reduction with very few postoperative adjustment and might be indicated in case in which close monitoring is difficult compared with deep sclerectomy. There are 2 publications of deep sclerectomy outcome in patients with uveitic glaucoma done in King Abdulaziz University Hospital. The latest one included 33 eyes of 21 patients, mostly having VKH, JIA, and Fox uveitis. The baseline IUP was 37.2 and dropped to the last visit to 14.7, while the number of medication was 3.2, which dropped to 0.4. And we can see that there is a smooth control of the IUP over the follow-up of 3 or 4 years. The most important postoperative complications were hypotony, shallow choroidal detachment, hyphema, compared to late complications consisting mainly of cataract development and progression. Most failures in patients who underwent deep sclerectomy occurred on the 22nd month, compared to 34 or 33 months in trabeculectomy. And that's the success rate of patients who underwent deep sclerectomy in uveitic glaucoma, which is almost identical to patients who underwent trabeculectomy in the previous presentation or in the previous slide. Now, when we look at the difference between deep sclerectomy and trabeculectomy in general, we know that the learning curve in deep sclerectomy is relatively short, while it's short actually in trabeculectomy. We need an open angle at least superiorly in deep sclerectomy. In trabeculectomy, it doesn't matter if you have closed or open angle. The postoperative visits in deep sclerectomy are frequent to monitor the need for goni puncture, while in trabeculectomy depends actually on the filtration rate. The filtration route is multifactorial in deep sclerectomy, while it's mainly subconjunctival in trabeculectomy. Deep sclerectomy can be blip independent, while we need a blip in trabeculectomy. The IOP reduction can reach low teens or even single digits in both. Postoperative complications are a little bit higher in trabeculectomy, and the postoperative inflammation is higher in trabeculectomy. Dupas et al. Published a paper in Eye Journal comparing the outcome of deep sclerectomy and trabeculectomy in patients with uveitic glaucoma. Well, he recruited 20 eyes in the deep sclerectomy group and 21 eyes in the trabeculectomy group. The baseline IUP was almost identical in both groups, But the difference is that, or the astonishing thing is that the outcome or the IOP control after 12 months was almost identical, but the inflammatory response 7 days after the procedure was much more higher in trabeculectomy, which is expected. But after 6 months follow-up and tight control of the inflammation, both groups will have almost identical inflammation in the anterior chamber. But the postoperative adjustment was higher in patients with deep sclerectomy compared to patients in trabeculectomy group. We have conducted a comparison between the outcome of deep sclerectomy and trabeculectomy in Saudi Arabia using the papers that we have previously published and the paper published by Al-Ubaid et al. The number of eyes included was 33 in the deep sclerectomy group and 70 in the trabeculectomy group. The mean age is almost identical, and the baseline IUP was almost identical, and the same thing applies to the number of medications. The etiology was mostly VKH and idiopathic in deep sclerectomy group compared with VKH and idiopathic in the trabeculectomy group. The mean follow-up period was 45.6 months in the deep sclerectomy group, while it was 77 months in the trabeculectomy group. And at the last point of follow-up for the deep sclerectomy group, which is considered and adjusted for the trabeculectomy group, the IUP was 14.7 compared with 16.6, and the number of medications was 0.4 compared with 0.8, again at the point of 48 months, which was adjusted in the trabeculectomy group. The post-op manipulation was higher in the deep sclerectomy, which was 36.4, mainly because of the need for goniopuncture, while it was 26% in patients with trabeculectomy. Complications were higher in the trabeculectomy group, mainly cataract development and progression, reaching 45.3%, followed by hypotony, compared with cataract development and progression, which is almost 30%, followed by hypotony. The overall success rate was 93.9% compared to 77.1%, while the failure rate is 6.1 compared to 22.9%, again on the same time point, which was 48 months. However, most failures occurred on 22 months in the deep sclerectomy compared with 33.4 months on the trabeculectomy group. When we move to other non-penetrating glaucoma surgeries such as canaloplasty, it acts on outflow resistance in uveitic eyes, which is exposed to steroid. We know that steroid increases the IOP via deposition of extracellular matrix. It's indicated in uncontrolled IOP, open angle, and we should not have peripheral synechiae. Conjunctival scarring and thinning are not an issue. It can be done in phakic or pseudophakic eyes and patients of young age group. However, we don't know about the direct stretch effect on the juxtacanalicular trabecular meshwork and the irritation caused by the tennoproline introduced to the Schlemm canal. There was a previous study done by Kalin et al., included 19 uveitic open-angle glaucoma eyes. The follow-up was 2.6 years, and the complete success rate was 73.3, and the failure rate was 15.5. They achieved a 55% IOP reduction, and the medication decreased from 3.7 to 0.4. However, longer series and much more studies are needed actually to evaluate the outcome of canaloplasty in uveitic glaucoma. Most complications were proline suture erosion to the anterior chamber, followed by transient hyphema and hypotony maculopathy after goniopuncture. Glaucoma drainage devices are indicated in cases of uncontrolled IOP, open or closed angle, conjunctival scarring, phakic, pseudophakic, or even ephakic eyes with uveitic glaucoma, and those who are having hypotony risks such as younger age group, but we should avoid the non-valved or really not close the tube very well using the vicryl suture. It can be used as a first procedure if there is some significant activity, but you are urged or you are actually you are in need to do the procedure, and it can be done after failed filtering procedure in uveitic glaucoma. Again, it can be a first choice for uveitic glaucoma. We can place the tube in the sulcus and extensive peripheral synechiae to avoid endothelial trauma, and it's more convenient because of the lower risk of immediate postoperative hypotony in patients who are at high risk of hypotony aside from deep sclerectomy. Now, Papadak reported the outcome of Ahmed implant in patients with uveitic glaucoma, where he reported the short-term complication included encapsulated blip up to 43%, transit hypotony 43%, and hyphen 21%. And they showed that occlusion of the tube and corneal decompensation have been associated with Ahmed valve glaucoma implant in eyes with uveitic glaucoma. So it's not only the high IOP, but also corneal decompensation as well. The success rate was reported to be 77% after 1 year and 50% after 4 years, which is actually pretty much high. While in Bervelt implant, according to the paper published by Aberrant et al. In Japanese Journal of Ophthalmology, they recommended using Bervelt implant for patients with Uveitic glaucoma. The cumulative probability of success was greater with patients with Bervelt glaucoma drainage implants than after trabeculectomy when they compared both groups. They showed higher frequency of early complication in the trabeculectomy group compared with the glaucoma drainage device group, and no significant difference were seen in the frequency of late postoperative complication between both groups. However, the most common complication were hypotony and cystoid macular edema, but there were no difference between both the Bervelt implant group and the trabeculectomy group. Another paper published by Borit al. In Act of Ophthalmology in 2010 evaluated the outcome of Multino implant in patients with Uveitic glaucoma and showed an 85% qualified success rate after 4 years, and the IP decreased continuously during the first year postoperatively. Therefore, we should wait for the complete outcome of IOP reduction in patients with Multino implant in Uveitic glaucoma. However, this statement is actually not completely accurate because there are some certain other factors that can play a role, such as the activity of the inflammation. Medications were slowly tapered up to 3 years after Multino implant. The most common complications were persistent hypotony, 6.7%, followed by corneal decompensation, which is reported to be 3.3%. So they reported the better IOP control in high-risk eyes for surgical failure of trabeculectomy with reduced bleb-related infection and comparable results with trabeculectomy and mitomycin C. When we compare variable or various glaucoma drainage devices such as Ahmed implant, Bervelt, and Multino, they almost have the same success rate. However, the one with the longest follow-up was the Multino implant, but the success rate on the intermediate and short term was almost comparable in between the three groups. When we compare the outcome of trabeculectomy versus glaucoma drainage devices, you can see that the dotted lines represent the glaucoma drainage devices, and it's almost comparable between trabeculectomy and glaucoma drainage device group as well. Looking at the outcome or the survival or the success rate of glaucoma drainage devices, trabeculectomy and deep sclerectomy, again, we can see that deep sclerectomy and trabeculectomy as well as glaucoma drainage devices are almost having the same success rate and survival. So again, this stress on the point of having actually adequate control of the inflammation. Lastly, we talk about cycloablation, endoscopic or external cyclodestruction of the ciliary body. We can use it if all other methods fail. There is a 100% rate of induction of uveitis and inflammation after the procedure. We should keep in mind that there is a risk of prolonged hypotony and phthisis, and it's reserved to patients with mild inflammation, unlikely to develop hypotony because of chronic inflammation when all other procedures fail. So in conclusion, surgery type is mostly individualized. Although the success rate is less than primary open-angle glaucoma, yet with prompt control of the inflammation, a safe IOP level can be achieved. Recently, we are getting higher results or higher success rate because of the better understanding of the inflammatory process and control of the inflammation. Therefore, the teamwork and the coordination with the vet specialist is crucial to have a successful IOP control. Thank you very much.
Is 27% of cataract complication compared to 40 plus in trabeculectomy. Actually, the majority of those patients, the cataract was not a complication of deep sclerectomy itself. We know already that non-penetrating, we are not open the globe, but most likely due to steroid induced. Second thing is the question to you before the open the floor. If you have a patient with controlled uveitis and open angle, you prefer to do non-penetrating or express shunt?
Well, the answer to this question actually classically will be the non-penetrating glaucoma surgery, because there is no bulk of evidence in the literature supporting the superiority of express shunt compared with non-penetrating glaucoma surgery. The second thing is that when we are doing non-penetrating glaucoma surgery, we are still not going inside the anterior chamber. It's true that we are not doing sclerotomy, not doing peripheral iridectomy in express shunt patients, but still, we don't know till now about the long-term outcome of such procedure on the inflammation.
Okay, now any questions? Yes, Saad.
Thank you, Victor. So my question is regarding the refractive anemia with the stages of any uveitic. synechiae early will prevent an angle closure and the need later for BI or for prolonged medication or surgery?
Yes. Well, regarding the release of peripheral anterior synechiae, it has been reported in the literature. Aside from being a uveitic glaucoma patient, it actually can work. But it depends on the duration of the synechiae, because the issue is not the synechiae itself. The issue is from preventing the aqueous or the aqueous turbulence from going to the angle. Once you prevent aqueous from going to the angle, what will happen simply is that the trabecular meshwork will collapse. With prolonged collapse, you will have trabeculosclerosis. That's why if you actually have an early intervention and release the synechiae and the aqueous can reach to the angle and trabecular meshwork, it can work, definitely.
But sometimes the synechiae develop during the acute stage, and when we examine, we find that maybe half of the angle closed with the synechiae, and we know that the other half still will work, but we want the whole angle to be open.
Yeah.
So intervention early with the acute stage.
If you have an acute stage, an acute inflammation, of course, this is a hot eye, and we don't prefer to touch a hot eye. Unless you are having a prompt control of the inflammation and you are still having, a progressive synechial angle closure, then at that time you have some justification to do your intervention. But there are still other factors that you should keep in mind, like the presence of high intraocular pressure. For example, if you have peripheral anterior synechiae and you have an acute uveitis phase, but we know that sometimes in acute uveitis phase you will have ciliary body shutdown, which will actually counteract for the peripheral anterior synechiae, so you will not have an increase in intraocular pressure. So once you have a controlled inflammation and the pressure is controlled, then at that time you need to assess, is this synechiae progressing or not? Because if you have, let's say half of the angle which is opened, then it should actually work and function to have, a controlled pressure after that. Once the ciliary body, return to action again and the shutdown stops. So, Professor Sam, if you have any comment?
I don't think there is actually indication for surgical intervention. Even sometimes the patient has synechiae, not in all angle, but the intraocular pressure is controlled. So you should have justification for interference, especially if the eye is inflamed, you cannot interfere to release the synechiae. And as you mentioned, peripheral iodotomy is very essential in uveitic patients, especially those who has 360-degree posterior synechiae. And my advice here is when you do the PI in uveitic patient, you should do YAG and argon at the same time. Because majority of patients, they have closure of the PI after you do it by YAG. So you can implement or adding some shots of argon around the YAG to prevent it to be closed by time. Any other question, please? So if there is no other question, thank you very much for your kind attention. Thank you.
We'll have the quiz now, Dr. Isam. The quiz.
Can you stay resident, please, for quiz?
We'll start the quiz now, huh?
She said the patient is fit. قالت لي no need to call the patient to relate it. This is routine. ترى المرضى the nurse. She said it's she will conclude that the patient is fit at the night or tomorrow morning. فلما كلمتها بالتليفون قالت لي لا خلاص. ترى انا اكلمهم يعني function قالت لي no need. The patient is fit.
So we'll start the quiz now, huh? So this is a gonioscopy image of the inferior angle. This is a spot diagnosis. A patient who underwent previous intraocular surgery. So a patient who underwent previous intraocular surgery, retina surgery, and that's the gonioscopy image of the inferior angle. So that's the gonioscopy image of the inferior angle of a patient who underwent previous intraocular surgery, specifically retina surgery. This is a spot diagnosis, huh? Inferior. So inferior image, huh? Next question, what's the procedure? And what's the spot size, type of laser, and power used? So what's the procedure? What's the spot size, type of laser, and power used? So it's very simple, huh? Patient who underwent previous filtering surgery. So what's the diagnosis? And how would you manage such patient? Recent filtering surgery, high pressure. So what's the diagnosis and how would you manage this patient? So this patient underwent previous surgery, intraocular surgery, and came with high intraocular pressure. What's the diagnosis? How would you manage this patient? It's clear for you, huh? So what's the procedure done here? And how does it work? What's the mechanism? Bonus question. Mention the composition of each drop, A, B, and C. And mention with each drop if we can use it in children or not. Children less than 6 years. So A, B, and C, mention the composition of each one, and for each one mention if we can use it in children or not. So we'll repeat again. What's the diagnosis? This is a gonioscopy image of the inferior angle in a patient who underwent previous intraocular surgery, specifically retinal detachment repair. What's the procedure? What's the spot size, type of laser, and power used? Post-glaucoma filtering surgery. Recent glaucoma filtering surgery, came with high IUP. What's the diagnosis? How would you manage this patient? You have his B scan, his UBM. Previous intraocular surgery. What's the diagnosis? How would you manage this patient? What's the name of this procedure and how does it work? What's the mechanism? And lastly, mention the composition of each drop, A, B, and C. And for each one, mention if we can use it for children or not. Well, we have 2 more minutes, huh? Yes, you have A, B, and C, huh? Mention the composition of each drop and if we can use it in children or not. Okay. Collect the papers, please. We'll give the answers down, huh? I think it's a very easy quiz, and you don't need time. خلاص شباب ولا باقي شيء؟ ما بقي شيء خلاص. So the first slide, who would like to answer? Ibrahim? Okay. So if this is the superior angle, silicone oil, so it's very simple, huh? طيب يا ساتر خلاص. طيب عبد الرحمن, what's the procedure?
Selective laser,
What's the spot size?
spot size 400,
Type of laser?
yeah,
Power used?
0.5 to 1
Millijoule or milliwatt? Joule, huh? So it's YAG, right? So what's the diagnosis? Because misdirection. Why it's not suprachoroidal? Why it's not pupillary block? Exactly. So how would you manage this patient? Yes, make PI. Why? It's aqueous misdirection, right? So why do you need to make a PI? Exactly. So we don't see actually a patent PI here, right? So you need to do a PI. So you have done PI, but it did not work. Okay, which is? And the patient is pseudophakic here, huh? So what you will do? So if the medical management failed, then you will do? So, and exactly. So will the power you'll be using in hyalodotomy lower or higher than that for capsulotomy? Higher. Why is that? Because you are actually aiming at the vitreous. You want to disrupt the anterior vitreous space. طيب, if such an intervention fails, what can you do? And so a key factor actually in successful management is to have a complete connection between the posterior chamber, vitreous cavity, and the anterior chamber. So you need to do PPV and exactly. So iridectomy, hyalozonulotomy, and iridectomy as well, right? Along with the PPV. What's the diagnosis? Silicone oil. How would you manage this patient and secondary pupillary block? PI and silicone oil removal, or somebody said something like that right now. Face down. Okay. Why face down? What would it help? Exactly. طيب, what's the procedure here? Deep sclerectomy. How does it work? So subconjunctival space, transconjunctival filtration, suprachoroidal space absorption, and scleral lake, and finally Schlim canal port. طيب, what's the composition of drop A, which is COSOT? Dorzolamide and timolol. What's the percentage? Okay. And the next one, can we use it for children or not? Yes. The next one, Combigan and timolol. Can you use it for children less than 6 years? Okay. Simbrinza, brinzolamide, and timolol or what? Brimonidine, right? Okay. So we'll break for 5 minutes, then we'll have the imaging conference, huh? Hello. ايش اسمك؟ هذا خطك؟ هذا واحد ما كتب اسمه بعد. هذا في اثنين ما كتب اسمها. من اللي هذه خطك انت؟ هذا؟ هذا؟
دكتور الظاهر ما كنت تسميك.
هذا ولدك ها؟ طيب.
اقدر اصلح اخطائي.
ها؟ والله يا اخي اللي تبيه. كم عددكم انتم؟ عبد العزيز. اسمك هو؟ انت مسلم ورقتك ولا لا؟ هذا بعد ما سجل اسمه. لا بس خليه هنا. هذه في واحد ما سجل اسمه. تعرف هذا خط من؟ ها؟ شوف لا من هذول كذا. لا لا 26 هذه نلغيها لأنها أصلا خلاص. يعني طب التخدير ما راح يجون طب الباطن. اي بعد طيب بسم الله الرحمن الرحيم. We'll be starting our imaging conference in glaucoma. So we'll dedicate this imaging conference for giving you basics and hints about the usage of UBM in glaucoma. So in general, if we talk about ultrasound in ophthalmology, we are talking about two things, mainly the B-scan and the ultrasound biomicroscopy, or the UBM. In ultrasound, we are using 10 megahertz probe, and the depth of penetration is 4 centimeter. Why is that? Because you want to reach, the last layer in the globe. You need to reach the sclera posteriorly. However, this will be on the account of a lower resolution, which is 940, which is actually equivalent to the thinnest area posteriorly, or in the posterior pole. While the UBM, we can use 35 to 80 megahertz probe, and the depth of penetration varies according to the probe used. If you use a 35 megahertz probe, you will have 6 millimeter depth, but a resolution of 50 micrometer. If you use a 50 megahertz probe, you will have 4 millimeter depth, but you will have a higher resolution of 40 micrometer. If you increase the megahertz up to 80 megahertz, you will have 2 millimeter depth of penetration, but with a much higher resolution reaching 25 micrometer. When the UBM first introduced in 1989 in Toronto, they had 80 and 100 megahertz. But they agreed lately that the best method is to have 50 and 35 megahertz to have the better compromise between the depth of penetration and the resolution. So if you use the 50 megahertz, you will have 4 millimeter depth and 40 micrometer resolution. So the good thing about UBM that it can allow you to image structures anterior to the pars plana and opposite to the anterior segment OCT. Remember that in UBM, you should have a good mixture between good depth and high resolution. A good depth that will allow you to reach the pars plana and evaluate the structures there, including the ciliary body, have good evaluation of the angle structures, and have good view of the iris and retro and pre-iris tissues in case of opaque media like in corneal decompensation or corneal scar. You can see here the ciliary processes with a higher resolution UBM. And whenever you perform a UBM, you actually want to know the structures that you are seeing. So basically, you will start with the corneal epithelium, which is the hyperreflective surface here, followed by the corneal stroma, then the corneal endothelium and desmet membrane, followed by the anterior chamber, then the lens. You will have the iris, you will have the ciliary body, and you will have a hyper echogenic point here, which represents the scleral spur. So it's at the area of intersection between the ciliary body, iris, and the sclera. So that's the scleral spur. Whenever you are reading or interpreting a UBM, you need to know that the scleral spur is an important anatomic landmark. So, if you use a 35 to 80 megahertz UBM, you will have variable penetration and variable resolution that we have mentioned before. You will have a radio-opaque shadow of sclera, and you will have a relatively radiolucent shadow of the cornea. And that's how you can differentiate between the sclera and the cornea by the radio-opaque and radiolucent shadows. So that's the corneal structure here, and that's the scleral structure here. You have the scleral spur here, and you have, what's this? Where does the, exactly. So the Descemet membrane terminates where? On Schwalb's line, right? So again, we go back to our structures. We have the cornea. What's this? The cornea what? Endothelium along with the Bowman. You have the stroma. You have endothelium along with Descemet. So it terminates here in where? Schwalb's line. You have the translucent area, which is the cornea, and you have the dense area, which is the sclera. Then you will have the iris tissue, and posterior to the iris, you will have the posterior chamber. You will have the lens, you will have the zonules, and you will have the ciliary body. So why do we need to use the UBM, or what are the benefits of using UBM? You can actually use it to evaluate the angle, to evaluate the anterior chamber depth, posterior chamber depth, corneal thickness, although the OCT is superior, iris thickness, configuration, and insertion in relation to the trabecular meshwork. You can have a judgment on the ciliary body thickness. You can look at the scleral thickness in case of what? Scleritis. It can help you to differentiate between scleritis and episcleritis. It can show you the IOL, location of thickness, but it cannot evaluate the lens thickness. But sometimes it can do. So this is an open angle, okay? So what's the structure here? Again, that's the cornea, and here, sclera. And that's the normal location or the normal configuration of the iris in UBM. Once you have a bowing iris anteriorly, so what does it mean? Simply, bowing iris. Pupillary block. So that's the normal iris configuration, and that's the bowing iris or the convex iris. You might have some cases in which the iris will be concave or bowing posteriorly, such as pigment dispersion. What's the unique thing about pigment dispersion? The angle, double hump when? Plateau iris, okay? So in pigment dispersion, you will have widely open angle. So look at the angle here. Look at the angle here, and look at the angle here. So widely open angle and bowing iris posteriorly. So if the iris bows posteriorly, what will happen to the posterior chamber? Exactly. It will become a little bit narrow, but you will have something which is more important here. Exactly. The contact between the posterior surface of the iris and the zonule. So that's the zonule here. So you will have more contact between the posterior surface of the iris and the zonules. UBM can help you as well to evaluate the presence of peripheral anterior synechiae. It can be seen clinically, but sometimes you cannot see it because of opaque cornea, because of corneal scar or decompensated cornea, especially if you are planning for penetrating keratoplasty. So what you are having right now is peripheral anterior synechiae. There is an iridocorneal adhesion. So how can you differentiate if this is actually a peripheral anterior synechiae or if this is the angle? How can you differentiate? Scleral spur, exactly. So where is the scleral spur here? Where do you see it? Hyperechogenic area, so it's here. And here, where do you see it? So that's the one, right? So that's the scleral spur, and that's all is a peripheral anterior synechiae, right? So you will follow a line between the ciliary body and the iris and the sclera. And the intersection of this line will be at this hyperdense area, which is the scleral spur. UBM can help you to evaluate cases of closed angle with anterior bowing of the iris, i.e., again, pupillary block. So here you will have a closed angle, right? You will have the iris pushed anteriorly because of the aqueous building posterior to the iris, because of the irido-lenticular contact, right, and resistance. So once you do your YAG PI, the iris will go back to its normal position, right? So that's your YAG PI, and that's the normal configuration of the iris. So again, normal configuration of the iris, and this is anterior bowing of the iris. You will have the termination of the decimate, which is Schwalbe's line. And here you will have what? Scleral spur. So that's the case of peripheral anterior synechia. How can you differentiate between peripheral anterior synechia and just being a normal angle? By what? Following the ciliary body and the iris. So if you follow the ciliary body and iris and scleral junction, you will end up having what? The scleral spur here. Okay? UBM can help you in cases of plateau iris with anterior ciliary process. So that's the ciliary process. Look at the location here. And look here. Is there any difference? Sorry, let me just go to the previous one. So that's the ciliary body. And look at the ciliary body here. So the bulk of the ciliary body is going where? Anterior. Okay? Compared with this one. Look at the bulk of the ciliary body. There is still some good space. While here, it's pushing anteriorly. So you will have here a closed angle or narrow angle according to the condition. Once you do iridoplasty, the angle will open. Again, that's a normal angle, and that's an area of angle recession. How do you know it's an angle recession? Scleral spur. So how would you see it? What will happen? First, look at the termination of the descemet membrane. Where does it stop? Here, right? Schwalbe's line. Look at the whole angle area. So it's really widened, right? So you'll have posterior displacement of the iris scleral insertion. So that's the iris. It's displaced posteriorly. It should be here in normal position, right? Look here. Look at the termination of the descemet. Look at the ciliary body. And look at the area of the scleral spur and compare it with the area here. So what happened to the iris? There is posterior displacement of the iris. There is widening of the ciliary body face with no disruption of the interface between the sclera and the ciliary body. If there is disruption, what will happen? What do we call this? Cyclodialysis, exactly. So you'll have here very wide angle, which reflects the presence of angle recession. If you evaluate the termination of the descemet membrane, i.e. Schwalbe's line, and you evaluate the position of the scleral spur and the insertion of the iris, you will see that this angle is really widened significantly. So this is a case of angle recession. After trauma, you might have angle recession, and you might have another thing, which is cyclodialysis cleft. So what will happen in cyclodialysis cleft? You will have detachment of the ciliary body from its normal location at scleral spur. So what will happen? There will be what? Direct communication between the AC and the suprachoroidal space, which is happening here. So subsequently, you will have supraciliary fluid. So here you will have supraciliary fluid. You see this blackish area? That's a collection of aqueous. If the density increase, then will it be aqueous or it will be exudate? Exudate, definitely. So if you have hyper-echogenic material depositing here in this space between the sclera and the ciliary body, then this reflects to you that there is an exudate. Mostly cases of uveitis, right? If you have a clear fluid, then that's a cyclodialysis cleft. If you have a very dense fluid, this is maybe hemorrhage, okay? So there is a direct communication between the anterior chamber and the suprachoroidal and the supraciliary body space. So that's what we call a cyclodialysis cleft. You might have iridodialysis, in which there will be disinsertion of the iris from its root. You might have zonular dialysis. Look at the lens position here and the lens position here, and look at the position of the ciliary body process, and look at the ciliary body process here retracting, and look at the zonules which are disrupted. So that's zonular dialysis. So is it clear for you here? Yes? Yeah. So you will have here a direct communication between the anterior chamber and the supraciliary space. So that's the sclera, right? And that's the ciliary body. Okay? So there should be no space between the sclera and the ciliary body. Look at the normal, UBM of this eye here. And look at the UBM of this traumatic eye. So that's the sclera, that's the ciliary body. There is no space between them, right? But here you have a space between them. So there is a fluid. If this fluid is clear, if it becomes hyperechogenic or if it becomes dense, then you might have exudate, like cases of uveitis. If it's very dense, then it can indicate the presence of blood. Okay? Now, if you have this communication between the anterior chamber and posterior chamber, then it means that there is detachment of the ciliary body from its normal location at the scleral spur, meaning from the sclera. So this is cyclodialysis cleft, right?
How would you say, when would you say this is cyclodialysis only? When is it cyclodialysis?
That's a cyclodialysis cleft. Cleft is the separation between both the ciliary body and the scleral spur. Okay? So that's the zonular dialysis. You can see the ciliary body in normal position here, and you can see the normal position of the lens, and you can see the lens moving superiorly or moving nasal or temporal, and you will have disruption of the zonules. Look at the attachment of the zonules here, and look at the area of rupture or disrupted zonular attachment here. Again, you might have ciliocoroidal effusion, in which the ciliary body will be edematous and enlarged. You will have separation from the sclera. You will have translucent supraciliary fluid, but you will not have direct communication between the anterior chamber and the supraciliary space. In the opposite to cyclodialysis cleft, you will have direct communication. Okay? So, in ciliocoroidal effusion, you will have edematous ciliary body, separation from the sclera, and translucent supraciliary fluid. So separation from the sclera, but not from the scleral spur, right? So it's still attached here. Cyclodialysis cleft, you will have detachment of the ciliary body from its normal location at the scleral spur. So there is direct communication. So that's the difference between ciliocoroidal effusion and cyclodialysis cleft. So there is communication between the anterior chamber and supraciliary space, while in ciliocoroidal effusion, still the ciliary body is attached at the scleral spur. You can use the UBM actually in evaluating the posterior chamber intraocular lens. So that's the normal position of the posterior chamber IOL. You will have the hyperreflectivity of the IOL surface, and it can show you the position of the optic and haptic and the presence of peripheral telangiectasia in case of complicated surgery with AC IOL, or in case in which the posterior chamber is subluxated into the sulcus. One part in the bag, one part in the sulcus. It can as well help you in evaluating patients with aqueous misdirection. So what will happen in aqueous misdirection? You will have shallow anterior chamber, you will have a closed angle, you will have forward rotation of the ciliary body, plus fluid in the suprachoroidal space, which can and cannot be present. So it's not necessary to have fluid in the suprachoroidal space. So the ciliary body normal position is like this, right? But because of the force by the aqueous and the posterior pushing mechanism, you will have anterior rotation, or what we call medial rotation of the ciliary body. So it's going anteriorly. Again, you have an extremely shallow anterior chamber or shallow anterior chamber in the early phases of aqueous misdirection, with a closed angle and forward rotation of ciliary body plus minus fluid in the suprachoroidal space. So that's the normal position of the ciliary body, and that's the ciliary body rotating forward. Again, that's an image of an aqueous misdirection, and after resolution of the aqueous misdirection, you will have the ciliary body rotating anteriorly. So, we talked a little bit about the UBM. Some of you might argue, why do we need to use UBM while we have the anterior segment OCT? There are some certain differences between the UBM and the anterior segment OCT. Number one, the UBM, it's a contact examination, while the anterior segment OCT, it's not a contact examination. UBM must be done in supine position, anterior segment OCT in the sitting position. You need a coupling agent, either fluid or gel in UBM, none in anterior segment OCT. You have 30 micrometer axial resolution and 60 micrometer lateral resolution compared with 5 and 15. in anterior segment OCT, the depth of penetration is 4 to 6 millimeter, while it can reach 1 millimeter in OCT, but you have multiple frames and multiple cuts. You have 40 to 50 micrometer overall resolution of the UBM compared with 15 micrometer resolution in the anterior segment OCT. The scanning dimension is 5 by 5 millimeter, while it's larger in anterior segment OCT. You can scan the whole anterior segment. It depends on the sound energy, while it depends on light energy in the anterior segment OCT. The scleral spur is less distinct compared with the anterior segment OCT. Here, the ciliary body view is good, while it's fair in the anterior segment OCT. So remember, posterior to the iris, UBM is superior to anterior segment OCT. It can image posterior to iris, while anterior segment OCT it cannot. Posterior lens capsule cannot be seen, while in anterior segment OCT sometimes can be seen with other modalities and with rotation of the camera. It's time consuming in UBM and need expert, while it consumes less time in anterior segment OCT, and needs skills in UBM, while in anterior segment OCT it just depends on simple operation. It can give you a clear image in opaque media or in opaque cornea, that's the UBM, while the corneal clarity equals actually image quality. So if you don't have a good corneal or a good media, then you cannot obtain a good imaging of the anterior segment. So just will present you some cases here, and this will be an interactive, session. So I need some of you to answer this. So this patient underwent previous trabeculectomy surgery, had hypotony and shallow anterior chamber postoperatively. So that's his anterior segment image, and that's his posterior segment, or the posterior pole. So can anyone just volunteer to tell me what's happening here? Abdurrahman Zaid. So what do you have here in the anterior chamber? Okay. So peripherally and centrally as well. So the patient is having hypotony and he underwent previous surgery. So what do you need to look at in the posterior pole? Rule out what with hypotony? Choroidal detachment. So there is no choroidal detachment, right? So if there is no choroidal detachment at the periphery, you need to rule out what? Apart from wound leak, cyclophotocoagulation cleft. So I hope it will work. So that's the UBM here. So what do you see here? Yeah, so there is fluid here, right? So if we follow this UBM here, so you can see here that there is like direct tract between the anterior chamber and the supraciliary space. And the fluid here is clear, right? So if there is a direct contact between the anterior chamber and the supraciliary space, what do we call this? Cyclophotocoagulation cleft. So do you think that this is because of uveitis? No, because the fluid here is clear. Okay. Is it hemorrhagic? No. Again, hypotenuse eye, and the fluid here is clear. Right. So that's an 80 megahertz UBM again. So look at the UBM here. So what's happening here? So have you seen the previous one? So look at the insertion of the iris here, and look at the fluid accumulating here. So there is a direct communication between the anterior chamber and the supraciliary space. You see it now? So that's the direct communication. So that's an 80 megahertz UBM, and that's a 35. So look at the difference in the resolution between both. So that's the 35, and that's the 80 megahertz. So that's another case, post-filtering surgery, had pain and high IOP. So where is Ibrahim Labed? So describe what's happening here. So that's the anterior segment image, and that's the posterior pole. Post-filtering surgery, had pain and high IOP.
Photo, I can see flat AC, diffuse uniform on the flat AC, Fundus photo shows optic disc with a hazy view to the fundus.
Okay. So generally the retina is flat here.
Yeah.
So post-filtering surgery, high IOP, pain, what do you think about? Three major things.
Pupillary block, aqueous
Pupillary block.
misdirection, suprachoroidal hemorrhage, which is unlikely because of flat retina.
Okay. So that's his B scan. So what do you think?
With the normal B scan, no sign of
So
suprachoroidal
no suprachoroidal hemorrhage, no choroidals, nothing at all, huh?
No detachment.
That's his UBM. So what do you find here in this UBM?
I can see as we chose.
So
as
what's
we
this
see-
structure here?
It's a cornea. There's epithelium. There's endothelium.
Exactly. And this,
This is AC.
the anterior chamber. And this is,
A lens.
and do you think that the space here is wide or
Very
narrow?
narrow
It's narrow space, right? So look at the ciliary body. Where is it?
It's pushing anterior rotation.
So it's pushed anteriorly.
Yeah.
So once you have this image, what do you think about?
Aqueous misdirection.
Aqueous
most likely.
misdirection. So the ciliary body is pushed anteriorly. There is extremely shallow anterior chamber, and the patient is having high pressure. So we think about
Aqueous misdirection.
aqueous misdirection. I think. Okay. So this is post-filtering surgery, has decreased visual acuity. I presented this several times to you. You should know it. So what's this? That's the desmet, and that's the
Intrastromal on its own.
exactly. And that's another advantage of UBM. So what's this here? Schlimm's canal. What's this?
Sharp line.
And what's this?
Clear spare.
Exactly. So- And this structure is iris, and that's the cornea, right? So endothelium with desmet, epithelium. So look at the area here. Okay. So what's happening here? That's what? Schlimm's canal. And this is a direct communication between Schlimm's canal and the anterior chamber. So there is rupture in Schlimm's canal, right? And what's this? That's the hemorrhage, huh? What's this very light, streak here? Desmet, exactly. So just to show you again. So that's ruptured Schlimm canal and intracorneal hematoma. So this 45 years old lady which has blurry vision and high IOP. طبعا straightforward diagnosis. So what do you see here? Posterior bowing of the iris. Is the angle open or closed? Why it's not synechial? Where is it? Is it here?
No.
Here? No, it's not clear then so much. So what do you see here? Posterior what? Posterior bowing of the iris. And the iris now becoming more flat. So what's done here? YAG PI, huh? So that's all for this imaging conference. Well, it's very small or very short and concise, but just to give you some basics and hints about UBM, huh? Do you have any question? Any question, please? يلا موفقين إن شاء الله. أيوه.